Greetings, I am Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's May 2018 issue. There are 4 articles this month that have been selected as our Editor's Choice or Highlight articles. Our Editor's Choice is an original article that sought to determine the association between thyroid status and mortality among a national cohort of more than 200,000 U.S. veterans with stage 3 non-dialysis dependent chronic kidney disease. It is authored by Dr. Connie Rhee from the University of California, Irving School of Medicine in Orange, California, and colleagues from several Veterans Affairs and other medical centers in the United States. Thyroid function is a prevalent yet under-recognized endocrine complication affecting a large proportion of patients with chronic kidney disease, and hypothyroidism is more common with incrementally impaired kidney function. Adverse cardiovascular sequelae may result from untreated hypothyroidism, such as cardiac and endothelial dysfunction, dyslipidemia, accelerated atherosclerosis, and electrophysiologic changes. Adverse cardiovascular sequelae may also result from hyperthyroidism, including atrial fibrillation, heart failure, and coronary ischemia. Thyroid dysfunction may influence morbidity and mortality in patients with chronic kidney disease. The authors conducted a historical cohort study using data from the Racial and Cardiovascular Risk Anomalies in Chronic Kidney Disease study, which examined U.S. veterans with incident chronic kidney disease receiving care within the Veterans Affairs healthcare system between October 1, 2004 and September 30, 2012. Patients who had undergone at least one measurement of TSH during that time period were included in the study, with the exclusion of patients who were receiving dialysis at the time of study entry. Among patients who met eligibility criteria, 90% had baseline TSH levels in the euthyroid range of 0.5 to 5 milli-international units per liter. 6.4% had baseline TSH levels of more than 5, and 3.4% of patients exhibited TSH levels less than 0.5 milli-international units per liter in the study. In the study, 67,706 all-cause deaths occurred, and the median at-risk time was 65 months. TSH levels greater than 5 and less than 0.5 were each associated with higher mortality risk across all levels. Granular examination of thyroid status showed that incrementally higher TSH levels of 3 milli-international units per liter or more were associated with increasingly higher mortality in baseline and time-dependent analyses. In conclusion, the authors observed that in time-dependent analyses, untreated and undertreated hypothyroidism and hyperthyroidism were associated with higher mortality compared with spontaneous euthyroidism, whereas hypothyroidism treated to target was associated with similar to slightly improved survival. This article is accompanied by an editorial by Drs. Maria Stan and Matthew Drake from Mayo Clinic, Rochester, Minnesota. Dr. Stan and Drake point out the strengths of the study based on its large sample size, the rigorous statistical approach that addressed the effect of several variables and potential confounders, and the accompanying sensitivity analyses. They note that in a population with chronic kidney disease, mortality might reflect concomitant comorbidity burden, with thyroid function test abnormalities as a manifestation of what has been referred to as sick euthyroid syndrome, and now better known as acquired transient central hypothyroidism. They also underscore the importance of the relationship between thyroid status and renal function in patients with chronic kidney disease, a common finding in clinical practice, particularly in older patients, and that the concomitant occurrence of chronic kidney disease and thyroid dysfunction exerts a negative impact on overall health. Dr. Stan and Drake suggest that consideration be given to the development of a public health policy in which thyroid monitoring is routinely considered in patients with non-dialysis dependent chronic kidney disease, and in identifying therapeutic approaches that may mitigate increased mortality risk in this patient population. Our first highlight article is an original article that considered whether weight gain raises ambulatory blood pressure in healthy subjects and whether a relationship exists between changes in blood pressure and changes in regional fat distribution. It is authored by Dr. Naima Kavazin and colleagues from Mayo Clinic, Rochester, Minnesota. Excess body weight is widely recognized as a leading contributor to morbidity and mortality, and current estimates show that 36% to 47% of the obese population suffer from high blood pressure, as compared with 20% of normal weight individuals. There is substantial variability in the disease risk conferred by excess weight when individuals are stratified solely on the basis of their body mass index. Since body mass index does not discriminate between lean mass and fat mass and does not take into account fat partitioning among various depots, evidence suggests that the anatomical location of fat accumulation is a key feature in determining risk status. The present study involved 26 non-obese healthy subjects who underwent an initial 3-day period of weight maintenance, and baseline body composition measures were comparable between groups. Following the baseline evaluation, subjects were randomized to an 8-week experimental protocol of either moderate weight gain, 5% increase in body weight, or weight maintenance. The weight gain group comprised 16 subjects, while the weight maintenance group involved 10 subjects. Subjects assigned to the weight gain group were instructed to increase their habitual food intake by increasing their portion sizes or by consuming 400 to 1200 extra calories per day via dietary supplements. Weight measures were obtained 5 times per week or more during the study, and caloric intakes were adjusted to achieve the targeted increase in body weight in the subjects who were assigned to weight gain. All subjects were advised to maintain their usual lifestyle routines throughout the study period, with the exception of avoiding caffeine and alcohol consumption for 24 hours before and on the day scheduled for measurements. Subcutaneous and visceral fat areas increased in those gaining weight, leading to enlarged total abdominal fat area following overfeeding. All body composition metrics were stable in subjects assigned to weight maintenance. Office measurements of blood pressure and heart rate did not vary significantly after the 8-week experimental phase in either the experimental group or the control group. However, increases in 24-hour systolic blood pressure, 24-hour mean arterial pressure, and 24-hour pulse pressure were evident after weight gain. Changes in mean blood pressure correlated only with changes in visceral fat. The authors conclude that the accumulation of abdominal visceral fat may be a critical determinant in the risk of hypertension associated with weight gain and obesity. Furthermore, they stress that even modest weight gain can contribute to an increase in blood pressure if the fat accumulation is predominantly visceral. The second highlight article is an original article assessing the effect of race on the incidence of aortic stenosis and utilization and outcomes of aortic valve replacement. It is authored by Dr. Fahad Al-Katani from West Virginia University, Morgantown, West Virginia, and colleagues from Charlotte, North Carolina, and Mayo Clinic, Rochester, Minnesota. As significant advances have occurred in the management of aortic stenosis in the past decade, the authors determined whether there are contemporary racial differences in the utilization and outcomes of aortic valve replacement. The analysis employed the nationwide inpatient sample, the largest publicly available all-payer administrative claim-based database. The study involved patients older than 60 years with a discharge diagnosis of aortic valve stenosis who underwent aortic valve replacement between January 1, 2003 and December 31, 2014. Using the nationwide inpatient sample database, the authors calculated the following: aortic stenosis-related hospital admissions, incidence density ratio defined as the relative difference in aortic stenosis-related admissions between whites and African Americans, and the ratio of aortic valve replacement to aortic stenosis-related admissions in both races. Patients with missing race data were excluded. The incidence of aortic stenosis-related admissions increased from 13 to 26 cases per 100,000 patient years in whites, and from 3 to 9.5 cases per 100,000 patient years in African Americans. The incidence density ratio decreased from 4.3 in 2003 to 2.7 in 2014. A total of 96,728 patients who were identified as whites or African Americans underwent aortic valve replacement during the study period, of whom 95.6% were whites and 4.4% were African Americans. The ratio of aortic valve replacement to aortic stenosis-related admissions was 11.3 in whites and 6.7 in African Americans, and this ratio remained constant throughout the study period. Unadjusted in-hospital mortality after isolated aortic valve replacement was higher in African Americans than whites. However, after adjusting for age, sex, clinical risk factors, hospital characteristics, and socioeconomic status, the differences in in-hospital mortality between the two groups was not statistically different. The authors conclude that the lower utilization rate of aortic valve replacement in African Americans is multifactorial, but may be partially due to the lower incidence of aortic stenosis in this population. Aortic valve replacement in African Americans was associated with longer hospitalizations, higher cost, and higher utilization of intermediate care facilities. The third highlight is a brief report that examines practice guidelines regarding the timing of lumbar puncture in patients on dual antiplatelet therapy. Such guidelines recommend delaying this procedure, often citing an increased risk of hemorrhagic complications, specifically the development of epidural hematomas. It is authored by Dr. Ivan Karabenkiov and colleagues from Mayo Clinic, Rochester, Minnesota. The authors performed a retrospective review of consecutive patients who were evaluated from July 1, 2011 to September 1, 2016, and identified 100 patients on dual antiplatelet therapy at the time of the lumbar puncture. The epidural hematoma rate was 0. 2 patients reported severe back pain in the first few days after lumbar puncture, one of which was ultimately found to be a consequence of nephrolithiasis, while the other self-resolved over the course of 1 week. In the 3 months after lumbar puncture was performed, no hospitalizations or imaging studies were required for any reason potentially attributable to the lumbar puncture. The authors conclude that additional studies are needed to review the safety of antiplatelet use before lumbar puncture, but withholding these agents increases the short-term risk of thromboembolic complications that may cause diagnostic delays. You can access these highlights and editor's choice articles free of charge during the entire month of May. When you visit our Mayo Clinic Proceeding website at www.mayoclinicproceedings.org, you will see other free content and articles published online ahead of print. You can also find links to our social media by clicking the buttons at the top of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find author interviews, 60 seconds video article summaries, and our Mayo Clinic Proceedings fireside chat recordings, which are available from our website on the home page as well as through iTunes. You will also find the next installment of our Pioneers and Legends video interview featuring Dr. Donald Schultz. And finally, our website lists many news stories that are based on articles published in Mayo Clinic Proceedings. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.